Welcome to APP virtual lectures. We have two viewer audiences today, APP to APP and My Catholic Doctor.
My name is Christina Condon. I specialize in transitional care and stroke recovery for patients and their caregivers. I also co-developed and lead the Transitional Stroke Program at Wake Forest University in North Carolina. I have served in roles as lead APP for implementation of the COMPASS trial and Director of Implementation for the TEAMS BP trial.
I am going to be talking about transitional care and chronic care management. Here are my disclosures. So today's objectives are really going to be talking about the gaps in post-acute care and transitions of care, talk a little bit about transitional care and chronic care management, and the journey from stroke care that our health team has been on, and talk more about generating revenue and sustaining transitional care models with payment models. So what happens today with patients after discharge? This tends to happen. I think we all know that when we send our patient out of the hospital, sometimes we're concerned with really what happens to them when they're home. And there are many things that can go wrong. Patients suddenly have a new disability. 44% of stroke patients can't walk independently at discharge. Patients stop medications due to side effects or cost, unrecognized cognitive issues, and increasing new comorbidities that they haven't had to manage prior, lack of primary care provider, and just multi-specialty follow-up burden. Often the patients don't know who is their quarterback in their care, and they have many different specialty visits to follow up with. There's also a lot of dropped referrals to resources that the patient may have need, like physical therapy, occupational therapy, and poor social support and community support. So many things can go wrong. There's a lot of caregiver challenges. Also, caregivers themselves can have poor health, and they're at risk for depression and isolation, and taking this new job on when they are caring for their loved one. There are many gaps in post-acute care. 70% of stroke patients do not receive comprehensive and coordinated care post-discharge. And this really increases the risk for secondary strokes, readmissions, prolonged disabilities, and many unnecessary costs to the health system and the patient, and overall really worsening healthcare disparities. And now more than ever, hospitals are being increasingly being held accountable for post-acute care outcomes, total cost of care for patients, provider and patient satisfaction, and minimizing health disparities. Stroke is one of the #1 causes of disabilities, and 80% of all strokes can be prevented. I really like this article. It talks about how readmissions might be driven by the quality of care coordination in the hospital prior to discharge within those first 7 days. But after 7 days, if the patient is readmitted, it really is those social and community related factors that are most relevant. So there's a lot of misconceptions about what is transitional care. But transitional care really is the entire care coordination and continuity of healthcare, from helping the patient and the caregiver from one healthcare setting to the other. And it could be from hospital to home, or transitions from nursing facilities to home. There really aren't many defined protocols that promote coordinated care and safe transitions, and they take a lot of time to implement. So CMS recognized this in 2013 and began offering ambulatory care practices, transitional care management service codes to be able to help bill and for patients being cared for at that care transition period. Within 48 hours of discharge, having that patient contact, and then seeing the patient within 7 to 14 days. There are many critical needs that patients have right after discharge, and the timely referrals are so important during that first 48 hours home. They often miss their therapy appointments or don't know they have a therapy appointment, which can set them back. There's also a bridge, the bridge from the communication from the inpatient to outpatient is lost. So the care teams that are discharging the patient, often the primary care doctors don't even really know the patient's had a stroke or any new comorbidities. And so there's this gap that happens. There's often a lot of urgent needs immediately after discharge. Patients are discharged, they don't have their Plavix prescription, increasing their risk of a recurrent stroke. There might have new signs or symptoms that need to be addressed, and they really don't know who to go to. There's really, who is the accountable team that is caring for this patient right after discharge? It's often that the patients get discharged and they are, the hospital teams are not accountable anymore for them, and they are sent out in the community in this vortex. And so we really need to prioritize the patient needs and drive the patient care throughout the continuum of their care journey. So just how successful are transitional programs? Looking at the literature, early supported discharge is really the only intervention that impacts outcomes, and components of transitional care are yet to be defined. And really, there are no performance indicators for processes of care after discharge. So my colleagues and I at Wake Forest University in North Carolina set out for this journey to look at how to build a successful transitional program. And prior to the implementation of our transition program, we really didn't have a very structured, standardized follow-through program. So we looked at how to structure a very nurse NP-led transition clinic to improve outcomes and reduce 30-day readmissions for our stroke patients. And so here are the factors that are associated with 30-day readmissions. And as you can see, increasing comorbidities, prior hospitalization, prior stroke were really of no surprise. And so even after adjusting for all these comorbidities, prior hospitalization, and stroke severity, our nurse practitioner RN-led clinic was still associated with nearly 50% reduction in 30-day readmissions. And so we took this a bit farther and really standardized our post-acute workflow, working at aiming to provide all of our patients with a very structured post-acute management plan. But we knew we needed to do more. And so through our learning health system and through the leadership of Dr. Pam Duncan, we set out the journey to take part in the COMPASS trial. COMPASS trial was a pragmatic trial throughout the state of North Carolina that randomized health systems and looked at usual care versus the COMPASS way of care, and really structuring transitional post-acute management for our stroke patients. And the aim was to increase functional status and decrease caregiver strain with secondary aims of readmissions. My role in the COMPASS trial was as lead implementation specialist, working elbow to elbow with all of the providers and APPs and across the state of North Carolina to truly try to implement these programs. And we found a lot of barriers, which is not surprising. And so challenges found among all the health systems were very, very similar. We collaborated weekly on weekly calls. There were several health systems that were very rural, small health systems to big health systems. And so many of the challenges were the same. Nurses were spending hours chart mining, trying to find their patient prior to discharge, trying to collect this data, which is really taking away the time that they had spent prior educating their patients and doing what they love to do. There were a lot of challenges in creating effective workflows, a lot of gaps in staff turnover, shared resources, clinic buy-in, and really, it took a lot of time to do this care coordination, and it wasn't easy. There was a lot of trouble identifying resources in the community. There might have been just, great resources down the street at these health systems, and they didn't even know it, because building that community and bringing everything together was really what our aim was to do. And we really looked at how can we make this easier? And there must be an easier way to have effective care coordination for our patients. So we leveraged technology, and throughout the years, with endless amounts of clinical feedback from frontline clinicians, from patient stakeholders, the multidisciplinary team members, Stroke CP was developed. And Stroke CP facilitates this provider team-based collaboration in care, utilizing a very streamlined workflow to enhance care planning and optimizing revenues for capturing transitional care management codes, chronic care management, and remote monitoring payment models. Stroke CP is commercialized through Care Directions. It allows the care team to be able to manage the patient at the continuum of care. And there are many different aspects to Stroke CP as a unique solution for care management, which was, again, created throughout the years of learning of all the barriers and challenges that health systems were facing. So it really is efficient in helping chart mine and collect outcome data, effective for helping nurses be able to manage better and their time, and to be able to really have time to educate patients prior to and after discharge, and empowering the entire healthcare team with being able to see where their patient is at any given time on the continuum of care, whether in the hospital, after discharge, or 3 or 6 months out. Improving that patient and provider satisfaction, facilitating the documentation to support billing, which has been a challenge, and automatically creating a very personalized care plan, which is one of the major benefits to this program. There are many functional and social determinants of health that drive the patient's ability to either be barriers or facilitators in their post-acute care and recovery. And there's many psychological concerns, physical concerns, health behaviors, and social determinants of health that impact their ability for recovery. The Stroke CP is able to create personalized care plans for the patient that are stroke specific and address these social and functional determinants of health. This is an example of a very personalized care plan for the stroke patient who might be having some trouble with managing their medications or having high blood pressure. Everything is going to be individualized and specific to the patient. It navigates the patient on their journey and allowing them to really take empowerment of their healthcare and be able to understand what are their risk factors for stroke and how do they find their way forward. It also has a provider report that is a way for the health team to be able to know what those social and functional determinants are and how to be able to help the patient, such as the patient may not know how to take their blood pressure, or they're not taking their blood pressure at home. They've had a lot of falls. They may not have a primary care doctor or a caregiver in the home, and they're at high risk for readmission. Or maybe the patient didn't get that home health service that they needed to get. And so when we're going to take care of patients after discharge, there's so many things that impact their care. And it takes a long time to be able to ask all these questions. Stroke CP quickly identifies these areas that are most pertinent and important to the patient to help them with their recovery, and quickly pulls it into documentation for the provider and then a care plan for the patient. It also connects the patients to local community resources. So for instance, this patient may have been having some cognitive challenges. And so it finds a local community resource in the patient's community that is going to be helpful for the patient and the caregiver. And that could be many different resources, such as pharmacy referrals or falls programs. The care team can include more local community resources that they might know. So this resource can be continuously evolved over time. Stroke CP also captures 90-day outcomes and any surveys that you may want to deploy to your patient via text or email, and really help to the care team to understand, how they're doing. What are the outcomes of these patients? What is the modified Rankin score now that they used to, that it's helped the patient in ways, and really be able to document and prove that they are helping the patient. Prior to utilization of stroke CP, our health team was seeing a very increased no-show rate at the follow-up visits. And after it was really helped optimize clinic efficiency and decrease no-show rates. That really helps prevent leakage of patients from your health system. And then streamlining the transitional care, chronic care management, and remote monitoring codes into the platform has it really helps increase that revenue. So I'm going to talk a little bit about transitional care management codes. And I just want to relay that it's really important when you start using these codes, if you haven't already. They've been out for quite a while. And now I think they're much more common than they used to be. But I would urge you to really talk to your billing specialist, because these codes are really helpful. And I think they can really help increase revenue to your clinic. But they do come with requirements. Like any of the codes I'll talk about today, you really need to be working directly with your billing specialist, because things may change, especially even month to month at times. So overall, the transitional care management codes do require a phone call within 2 business days. And then this is 2 business days after a hospital discharge or an inpatient OB stay, a nursing facility, but it can't be utilized after an emergency room visit. So the whole point is to prevent the patient from coming back to the hospital and being readmitted. After the phone call within 2 business days, the patient will have a 7-day follow-up or a 14-day follow-up, depending on the complexity of the patient. And these are really helpful to be able to, see that patient face-to-face right after the hospital stay, and really help them through that transition. So now I'm going to talk a little bit about chronic care management. And these are newer. It is a little bit harder for health teams to try to streamline these codes, just because there's a lot of more criteria involved. I'm going to first show you a video about how this is very impactful and meaningful to our patients and our caregivers. I think it helps us as clinicians to kind of see the overall impact that it can have, and really transforming care in a way that is not only meaningful and improves the lives of our patients and caregivers, but also the care teams.
Rayford is a typical rural North Carolina community. We never know what we're going to encounter. We can spend hours of care beyond face-to-face interactions, yet we were not being paid for those services. We did know that we had to do something different. At last, the chronic care management program had a way to capture those events of care documented and actually be paid for it.
With chronic care management, patients don't feel like they're alone anymore. They feel like they have that extra person that they can trust. Their health is in good hands.
We are changing our interactions, reaching out into the home of the patient via the portal, via the telephone, engaging people in their own care and assisting them in making proper judgment calls about serious conditions.
There's a lot of damage that I had from being in the military and in the war in Vietnam. The chronic care management that I received was something that I needed in order for me to maintain my health.
My group, I can actually compare those who are participating, those who are not. This truly has benefit in terms of outcome. By reaching out to the patient and getting a sense of what's occurring on their own well-being, we're able to intervene before it escalates. So if we shift in our behavior in providing care for people who have chronic conditions, we actually have an impact in terms of the healthcare costs for the entire community. My love of medicine comes from the interactions with people. If I can do my part as a physician, enhancing the care of an individual, that's pretty special. That's my motivation.
So there's a lot of details to be able to utilize chronic care management codes. Again, talk to your billing specialist, but just to go over a few highlights from chronic care management and how to utilize these in your practice. Really, there has to be this enhanced non-face-to-face communication. So it's all of that extra time your staff uses to manage the patient's care transitions. There's several codes that you can use. The patient has to have 2 or more chronic conditions, which now a lot of our patients have many comorbidities. There has to be a patient consent and a personalized care plan that is included in the EHR. A lot of the documentation has to be documented into the EHR, and a copy of the care plan would be provided to the patient. The care team would have to make sure they are available for the patient and their caregiver 24/7 to have access for any kind of urgent needs. And there's many more requirements that you can look at on the CMS Medicare website that can help walk you through how to utilize these for your patients. There's also a lot of great webinars and toolkits to help you get started. And so there's also great remote patient monitoring codes. And these codes can consist of being able to monitor your patients in many ways. So for diabetes or high blood pressure, weight management, the codes can include setup of the devices. And really you have to have this consent, this patient face-to-face visit to really help the patient understand what is going to be included in the remote monitoring. And you can utilize chronic care management and remote patient monitoring in the same at the same time, but you really can't use any of the remote monitoring documentation to be used toward the chronic care management documentation. This slide really summarizes all of the great ROI benefits that effective coordinated transitional care can have for patients and health systems. And so it may not come to a surprise to many of you that really clear coordinated care can help improve patient outcomes, decrease patient unnecessary readmissions, and help improve your staff and care team efficiency and satisfaction. And so there's a lot of great ways to optimize billing mechanisms to help improve the coordinated post-acute care for patients. Thank you so much for allowing me to talk today. And I'm really happy to have been able to share all of this great information on transitional care management and chronic care management and how you can improve your transitional care for your patients. Thank you.